Hi friends, today we will be discussing the recently conducted INI-CET November 2022 Psychiatry recall based MCQs. So before getting started, let me say the questions that I am discussing is purely recall based. So there will be some confusions in the options, but it's okay. Like the main intent here is to go through the important topics, right? So let's get started. So the MCQ first one. So here they have given an MCQ of 55-year-old chronic alcoholic with daily intake comes to casualty with history of seizures, auditory hallucination, fearfulness, persecution, and last drink was 2 days back, and the best management is. See friends, very importantly, alcohol is a very important topic. Multiple times they have been asking in INI-CET and NEET exams. And this time also there were two questions directly from alcohol withdrawal management. So I have already discussed after cessation of alcohol withdrawal. Okay, after cessation of alcohol, we have something known as alcohol withdrawal. So alcohol withdrawal always follows a timeline. Okay, so these days, first day after cessation, first day will have tremors and autonomic arousal. Tremors and autonomic arousal. Second day will be seizures, and third day will be delirium tremens. Delirium tremens. Fine. So here, chronic alcohol. Last drink was around 2 days back. There was history of seizures, auditory hallucination, fearfulness, persecution. There was also, some students told there was clouding of consciousness in the MCQ. So the answer, the diagnosis here is, it is delirium tremens, or it is definitely withdrawal, or withdrawal. So what is the treatment? Drug of choice is always benzodiazepines. Always benzodiazepines plus thiamine. Plus thiamine. Okay. And please note, in benzodiazepines the drug of choice is, first one is chlordiazepoxide. Chlordiazepoxide. And second one is diazepam. And diazepam, right? So here the answer, and it was a multiple answer type question, so the answer is diazepam and injection thiamine. The answer is diazepam and injection thiamine. Please note here. So this is a very important topic. Okay, alcohol withdrawal timeline I have told, 1 to 3 days. Okay, so this is a kind of easy to, you can easily remember. So naltrexone is used only for after the detoxification is maintained. After detoxification we use naltrexone as anti-craving. It is an opioid antagonist. Okay, injection haloperidol is an anti-psychotic. So the answer is diazepam plus injection thiamine. Right? Fine. So coming to our MCQ 2. So here it was a match the following type question, and this was centered about impulse control disorders. Okay, impulse control disorders. Impulse control disorders. Fine. So this impulse control disorders we have already discussed. So in this, what is kleptomania? Kleptomania means compulsive stealing. Okay, the patient will have irresistible urge to steal products of non-economic value. For example, they go to a shop and they steal. They have an intense urge to steal, and the anxiety buildups during that time. They have the intense urge to steal and the anxiety buildups, and at the top of that anxiety they steal certain objects of non-economic value. That is known as, it is compulsive stealing, kleptomania. Dipsomania, as the name suggests, it is compulsive or binge alcoholic drinking. Compulsive or binge alcoholic drinking. Mutinomania is pleasure is sought by mutilating animals. Mutilating animals. And pyromania is setting of fire. Pyromania is setting of fire. Please note, I think the next time in impulse control disorders, the important things are previously trichotillomania and skin excoriation disorders. Skin excoriation disorders are placed in, previously it was placed in impulse control disorders, but new classification in both in ICD and DSM, they are in obsessive compulsive and related disorders. Obsessive compulsive and related disorders. Please note, they might ask. And very importantly, pathological gambling. Pathological gambling is, they are placed in addiction. Just please remember this. Pathological gambling, they have moved to substance use and related disorders. Okay, in addictive disorders, right? Fine. Yes. Coming to MCQ 3. 15-year-old came to OPD with history of sudden onset blindness since last 2 to 3 hours. On examination, it is found that she is not concerned about this blindness. She is not concerned about this blindness. Systemic examination is unremarkable. Okay. Reason, there is a recent stressor, the death of the mother. Okay, it's a life event. She was talking about her during the course of history taking. Which of the following is true? Please note. Here they are, the MCQ or the topic of discussion is conversion disorders. Conversion disorders or dissociative disorders. Dissociative disorders. Okay, dissociative disorders. First thing for conversion or dissociative disorder, the other name is hysteria, the old name, which is known as wandering uterus. Wandering uterus. Okay, hysteria. Please note, here the first criteria is recent stressor. Recent stressor followed by the dissociative symptoms. Oh, here there is a recent stressor. Yes, the death of the mother. And very importantly, what is happening is that there is sudden onset blindness, but the affect is not appropriate with that. So here they have told she is not concerned. Okay, she is not concerned. So the affect is not matching. The affect is not matching with the loss, right? Because if sudden onset blindness, the patient will be very much distressed, right? But she is not having that appropriate emotion. This is known as labile indifference. Labile indifference. Okay, the affect is not matching with the emotion. This is known as labile indifference. And this conversion disorder or dissociative most commonly seen in females more than males, even both in adults and childhood. So I think yes, that clears the answer. So here incidence in childhood is females more than males. I have detailedly discussed in our this one, right? So labile indifference is very important. Okay, question that they will ask. MCQ number 4. Therapeutic concentration of lithium to be maintained for prophylaxis, that is for long-term maintenance treatment. Please note, very important question, lithium and its side effects. Multiple times I have discussed. So lithium has a narrow therapeutic window. That is why therapeutic monitoring is necessary, right? So the therapeutic levels needed is 0.6 to 0.8 for maintenance treatment, 0.8 to 1.2 for acute management. Fine. 0.8 to 1.2 milli equivalent per deciliter for acute management. Toxicity starts anywhere more than 1.5 milli equivalent per liter. toxicity starts anywhere more than 1.5 milliequivalent per liter. So this is our understanding. Okay, this I have taught in our classes also. So here, if you see, therapeutic concentration of lithium to be maintained for prophylaxis. There can be some, like what you say, questions based, recall based differences. So here, for prophylaxis, that is for maintenance, it is somewhere 0.6 to 0.8. But our closest option here is 0.6 to 1.2. Our closest option here is 0.6 to 1.2. Anywhere more than 1.5 is what? Toxicity. Right? Lithium, other MCQ that they commonly ask, therapeutic drug monitoring is done after how many days of starting lithium? 5 days of starting lithium, because the T half is 1 day. It will take 5 T half for steady concentration, 5 T half for plasma steady concentration, for plasma steady concentrations. You understood? That is why after 5th day of starting lithium, we check the therapeutic drug monitoring. Very importantly, in toxicity also, there are some other important questions that we should note. In toxicity, very importantly, there are coarse tremors and fine tremors. Fine tremors is side effect, coarse tremors is toxicity. And please note, the treatment of choice is, if it is mild to moderate toxicity, stop the drug, rehydration. Okay, rehydration. If it is severe, that is more than 3 to 4, if the milliequivalent per liter, it is dialysis. It is dialysis. Right? You can remember lot. Okay, the mnemonic is lot. So coming to the next MCQ, number 5. Again, alcohol related questions. Chronic alcoholic patient presented to casualty with seizures. Last thing was again 2 days back. On investigation, his LFT is deranged. Okay. So I told the drug of choice is benzodiazepines. Drug of choice is benzodiazepines. But here, as the LFT is deranged, we have to give liver-friendly enzyme, liver-friendly benzodiazepines. What are that? Okay. So, lorazepam, oxazepam, and temazepam. They are liver-friendly enzymes. Liver-friendly benzodiazepine. Okay, you can remember by mnemonic lot. So, here oxazepam is the answer. Oxazepam is the answer. Right? Again, second question from the same topic. Right? Coming to the 6th MCQ. Which of the following side effects are seen more with carbamazepine over oxcarbamazepine? Please note there is some difference. I think the question was which of the following side effects are seen more with oxcarb more than carbamazepine. Oxcarb more than carbamazepine. Right? Please note, both carbamazepine and oxcarbamazepine, they are anti-epileptic drugs and they are mood stabilizers. They are mood stabilizers which is used in bipolar affective disorders. Oxcarb is a congener of carbamazepine. Oxcarb in carbamazepine, skin reactions is more. Here skin reactions is less. That is rashes and skin reaction. This is more in carbamazepine. Visual side effects are more in carbamazepine. Okay, but hyponatremia is more in oxcarb. Hyponatremia is more in oxcarb. Other MCQs related to carbamazepine are, it is also an anti-epileptic, I have told, and is also a drug used for trigeminal neuralgia. Trigeminal neuralgia. Okay, so that is an important topic. This is a topic of interest in psychopharmacology. and mood stabilizers, right? Coming to MCQ 7, again psychopharmacology, very direct question. Drug used for smoking cessation is? Drug used for smoking cessation is varenicline. It is an alpha 4 beta 2 nicotinic partial agonist. Fine. Other drug that is used is bupropion, which is an NDRI, right? Very important. Buspirone is an anti-anxiety drug. It is an anti-anxiety drug. Naltrexone is used for anti-craving in alcohol. Anti-craving for alcohol. Valproate is a mood stabilizer. Okay, NDRI. These are the two smoking cessation drugs. Okay, coming to next MCQ. 8th. Not true about disulfiram. Disulfiram is used as an aversive therapy, or it is a deterrent agent. Okay, it is a deterrent agent. It is basically an aldehyde dehydrogenase inhibitor. So what happens is that acetaldehyde get accumulated. Acetaldehyde, this is right, acetaldehyde accumulates. It is an deterrent agent, not anti-craving, right only. Starting dose is somewhere 200 to 250. The correct answer here is it inhibits aldehyde dehydrogenase. Okay, it inhibits aldehyde dehydrogenase. It is not an anti-craving agent. I told anti-craving agents are naltrexone, baclofen, acamprostate. Okay, these are the anti-craving agents. Disulfiram is an aversive therapy. Okay, alcohol gets converted into aldehyde. So this aldehyde is metabolized by aldehyde dehydrogenase. So this aldehyde dehydrogenase is inhibited by disulfiram. So which gets accumulated? Acetaldehyde gets accumulated, right? And when acetaldehyde gets accumulated, it causes disulfiram ethanol reaction. What are the symptoms? Autonomic arousal, flushing, vomiting. This unpleasant reason, this is an unpleasant reaction, and patient will have that aversion towards alcohol, right? So very importantly, the next question that they ask in disulfiram is, after how many hours of last intake of alcohol we can start disulfiram? Is 12 to 24 hours. Please note, after the last intake of alcohol, after 12 to 24 hours, we can give disulfiram, right? So 3 questions from, like 2 questions directly from alcohol withdrawal, and other question, 3rd question from pharmacology, psychopharmacology of alcohol. Okay, this is a little controversial question. MCQ number 9. SSRI use in pregnancy increases the incidence of following conditions in a newborn. So they were telling this is multiple, there were multiple options correct. See, if you ask me, this is a tough question for undergraduate level, but one of the most common reasons, or one of the most common problems when the mother uses SSRIs is persistent pulmonary hypertension. Okay, that is this. And they have told there is chances of some neurodevelopmental disorders also somewhere research. So that can cause some delayed milestones. This persistent pulmonary hypertension can cause low PAR score. ADHD, see, I'm not sure. If yes, ADHD is a neurodevelopmental disorder, we can add this one. But definitely low PAR score and persistent pulmonary hypertension I can C. And these are the three options which I am sure of, in the sense like the recall. According to recall, this option, like some of the people told, but I am not sure. There's someone told delayed motor development or something. So I think the most common is persistent pulmonary hypertension, and the most heterogenic is paroxetine, and the safe SSRI is sertraline. Sometimes they may S4S. Safe SSRI is sertraline. Okay, please note. Coming to MCQ 10. This is paraphilias. So it was a doable question. What is necrophilia? Necrophilia is sexual attraction towards corpses. Okay, they have sexual attraction towards dead bodies. Eonism is transvestism. Okay, that is sexual gratification by wearing female clothes. What is frotteurism? Frotteurism is act of rubbing, that they get sexual gratification by rubbing genitals against females. Like exhibition is sexual gratification by exposing genitals to strangers. Okay, this was a doable question like for paraphilias, right? So coming to MCQ number 11. Yeah, this also multiple times they have asked. Actually, last time also they asked sort of similar question. I was not able to recall all the options. So the question was appropriate definition of stress. So let's not get into the options. So we'll do according to Hans-Seil's definition of stress is, it is a non-specific response of the body to any demand for change. Okay, that is when the demand exceeds, when the external demands increases, definitely there will be our internal needs also will increase. So stress is something, a non-specific response of the body to any demand for change. Just remember these keywords. It's a non-specific response to the body for any demand for change. So I think something similar definition was given, and that will be the right answer. It is not mental tension or it is not pressure, right? So next MCQ, last MCQ. Here also, like, I was not able to recall all the options, but let's go to the concepts proper. Schizophrenia patient on treatment with antipsychotics, which of the following is not true? Please note, I will just start writing the concepts. Okay. So very importantly, tracks in schizophrenia. We have mesolimbic, mesocortical. Okay, we have mesocortical, nigrostriatal, and tubulo-infundibular. Okay, fine. So we all know dopamine in mesolimbic in schizophrenia is increased, which is the cause for positive symptoms. That causes delusions and hallucinations. In mesocortical it is decreased, dopamine, that causes negative symptoms, which is known as anhedonia, apathy, evolution, all A symptoms. Okay, please note, when we give treatment, that is antipsychotics, they block D2. That is, I'll tell you, antipsychotics block D2. So improvement happens. So positive symptoms. Negative symptoms, no much improvement, because it is blocking. Again, it is going to decrease. No much improvement. Yes. Nigrostriatal pathway is implicated in Parkinson's, right? Dopamine nigrostriatal pathway is used for initiation of movements. So what happens when we give D2 blockers? Dopamine nigrostriatal pathway decreases, right? Dopamine nigrostriatal pathway decreases. So it causes extrapyramidal symptoms, that is drug-induced Parkinsonism. Side effect, right? Side effect. Dopamine tubulo-infundibular pathway. Dopamine, what happens? Dopamine blocks prolactin release in tubulo-infundibular pathway. Dopamine blocks. Here when we give D2 blockade, this blockade, double blockade, which means what happens? There will be increase in prolactin. There will be no inhibition, increase in prolactin, which causes galactorrhea, right? If you remember this, it's very easy to answer our questions. So, there are two types of antipsychotics, typical and atypical. So, what is typical? Typical is based on D2 by 5-HT2 blockade. So, if it is more than one, that is, if D2 blockade is more, it is typical. It is more than one. If 5-HT2A basically blockade is more, it is atypical. It is atypical. So, atypical antipsychotics has 5-HT2 blockade, which is helping to decrease. Negative symptoms, the new study shows 5-HT2A blockade will help in decreasing. This is right. D2 blockade in mesolimbic pathway helps in decreasing positive symptoms. That is also right. Anticholinergic effect, reduction of EPS. That is also right. I told no. Because for treatment of EPS, what will we give? We give anticholinergics, right? Like trihexyphenidyl, that is benzhexol or Phenergan. Right? So, typical and atypical. So, typical antipsychotics, more EPS. Atypical antipsychotics, less EPS. Please note, 5-HT2A is for antipsychotic action. 5-HT2C is for what? Side effects. That is obesity and sedation. Obesity and mainly sedation. Okay, weight gain and sedation. So that's all about the discussions of INI-CET, both the sessions, morning and afternoon session questions. Yes, there were good number of questions from psychopharmacology, alcohol withdrawal related topics. So I'll again release some important questions or important topics in psychiatry. Thank you.